I'm Darlene Hutton with QRS Educational Services. This is our second of 7 series in the Airway Management YouTube videos. This segment will be looking at advanced airway, just an introduction to it. I'm going to talk about the pros and the cons and show you examples of endotracheal tube, laryngeal mask airway, and King LT. These will all be featured in more detail in subsequent videos. So when we're talking about the most definitive, the most respected advanced airway, it is the endotracheal tube. The sizing depends on the decision of the person inserting it, whether it's the physician, the RT. For an adult, the average size is 7.0 to 8.5. This here is an 8.0. In the package, this is another example. This one is smaller in size. You will notice that there is a cuff that you will need to inflate to insert this. And the secret of inserting anything that involves a cuff is you want this to be soft like a grape. We don't need to insert 10 cc's of air. It's whatever it takes to ensure we have a good seal. So that soft grape is what we're looking for. This is the most definitive because it provides the best protection against aspiration. This tube will go past the pharynx. It will go directly down into the into the trachea, and the air will be coming out of here and into the patient's lungs. So if there is imminent vomiting to happen, the risk of aspiration is far less because this tube is fully obstructing or fully occluding the trachea. This patient would need to be suctioned, of course, but in terms of aspiration, the risk is a little bit less. The downside is the skill required to insert this. Because you need to view the vocal cords, and a laryngoscope is required, and quite often there's an assortment of other equipment that might also be used. It might be a glide scope, it might be a bougie, it might be the stiff tube. We'll talk about that in more detail. So for emergency purposes during a code, if the provider attending the code is not skilled enough or hasn't done enough of these, then this probably is not the advanced airway of choice. If that patient survives their code and requires further ventilatory support, then post-arrest, we could look at doing an advanced airway at that time. But certainly, if a patient is in a situation surrounded by a strong team and the physician is skilled or the RT is skilled, then the earliest that this gets in, the better, because what that means is once you have an advanced airway in during a code, you don't have to keep doing 30 compressions and 2 breaths. You can now do continuous compressions, and you would administer 1 breath every 6 seconds. The next type of advanced airway that you're going to see more frequently, actually, than the last option is called the LMA, the laryngeal mask airway. This, along with the last one I'm about to show you, they are called supraglottic airways. And that means that the tube does not go past the glottis. And they are blind intubations. They are very, very easy to use. This is an LMA, and this LMA is actually is fully inflated, and in real life it would not be. You open the package and you would need to inflate it once it's inserted. But this is a blind intubation, meaning that you just shove it into the mouth, and when it meets resistance, it's because the tip has lodged into the esophagus. So you would then go ahead and inflate your cuff. You would attach your filter, then your ambu bag, and you would deliver breaths, 1 breath every 6 seconds. Sizing for this is based on the patient's weight. So an average size for an adult, 30 to 60 kilos, this would be about that range. So the pro of this, easy to insert. The con is it does not protect against aspiration. So if this patient is obese, if there's trauma where there's a risk of vomiting, quite pregnant, this would not be an ideal tube to insert. But for those of you working in recovery room or in the OR, doing general elective low-risk surgeries where patients are NPO, this is actually one of the more frequent devices used for airway management. If a patient does have this and they are about to vomit, just take it out quickly. You don't need to worry about inflating because it hasn't gone past the vocal cords. Another example is the eye gel. The eye gel, as you can see, does not require inflation. So you would lubricate it, shove it in until it meets resistance because it's at the entrance of the esophagus, attach your ambu bag, and the patient would have the air coming out here, going up the trachea into the lungs. Another example of laryngeal mask airway, this particular one is called a Fastrach. So different things that have been developed over time. The next advanced airway, which is also supraglottic, is called the King LT, kind of a second generation. The first generation LTs kind of had some inherent flaws. These ones are actually really nice. They are sized based on the patient's height. So for example, this size here, it says 5 to 6 feet, okay? So again, it's a blind intubation in that you just insert it in, and just the way the trachea and the esophagus are situated, it will go into the entrance of the esophagus. Once you meet that resistance, you're going to inflate your cuff, and it will inflate both of these at the same time. When this feels like it is a soft grape, then you don't need to insert or inflate any further. You attach your filter, your ambu bag, and then you assess to ensure that you are getting air entering. Air will come up here into the trachea, into the lungs. And the real pro of this, two things actually, it does protect better against the LMA in terms of risk reduction for aspiration. But the second thing is you can also do NG suctioning at the same time that you are providing positive pressure ventilation. So you would have your ambu bag attached here. You have a tube entry at the back. I don't know if you can see it. And just for demonstration purposes, I'm going to take this white tube, which we're going to talk about in more detail, and I'm going to insert it into that back port so that you can see it better. It will go down into the esophagus, continuing to go down into the stomach. And here you have the best benefit of this type of device. You can continue to do positive pressure ventilation and also do NG suctioning. The downside of this is that the pressure on the soft tissues can be so great that it can cause ischemia to the surrounding tissues. So the recommendations are not, it's not a long-term airway management device. If your patient is in a cardiac arrest in this type of presentation with the LT and they survive, what will happen as soon as we're in the post-cardiac arrest part of their algorithm is we would look at switching this out for an endotracheal tube. So that's the introduction to the 3 options for advanced airways. If you like this video, please give me a thumbs up. And I'd also love if you subscribe to my channel. I'm going to be producing a lot more of these. Again, I'm Darlene Hutton with QRS Educational Services. Thanks.